Hi, this is Dr. Pedro Ramirez, editor-in-chief of the International Journal of Gynecological Cancer. And today I have the great pleasure of speaking with Ramlogan Sowamber from the University of British Columbia in Vancouver, British Columbia, Canada. The topic of this discussion is going to be our February lead article, and it's titled Oral Contraceptive Use is Associated with a Reduction in the Physical Size of Fallopian Tube p53 signatures. Ramlogan, welcome to the podcast. Thank you for accepting our invitation, and thank you and your group of co-authors for submitting the article to our journal.
Thank you so much, Pedro, for having me. Greatly appreciate being on this podcast and sharing my thoughts about our paper and also about salpingectomy in ovarian cancer as well.
Excellent. So we have quite a bit of questions, and hopefully we'll be able to get through all of these in the podcast. Wanted to start by discussing what we know about the impact of oral contraceptives on ovarian cancer risk reduction.
Yes, so this is actually quite a great question because there's quite a bit of work that has been done looking at OCPs, oral contraceptives, and ovarian cancer risk reduction. Primarily, these studies have been done epidemiologically, so a lot of them have been associations. But I'd like to just preface my answer by just first talking about ovulation. And when we talk about ovulation, there was this theory put out many years ago called incessant ovulation theory. And this basically says that multiple rounds of ovulation would could give rise to changes in the fallopian tube epithelium. And this is primarily because follicular fluid consists of mutagens such as reactive oxygen species, apoptosis, rescuing proteins such as hemoglobin, as well as other types of proteins that would impact the fallopian tube. And so a lot of this work around OCPs have shown that OCPs may reduce ovulation, which could prevent ovarian cancer. So, so a lot of these studies, like I mentioned, are epi-based. There's quite a few large studies out there, including meta-analyses that have shown a significant reduction in ovarian cancer following OCP use. Some studies generally put OCP use at any use of OCPs at reducing the risk of ovarian cancer by 30 to 50%. And if a woman has used oral contraceptives for 5 or more years, uh, typically these studies have also shown that there's a 50% lower risk of ovarian cancer compared to their non-user counterparts. And this benefit also can be applicable to the high-risk mutation carriers. So those are the BRCA mutation carriers that, the BRCA mutation carriers are at increased risk for developing ovarian cancer. So there is something interesting to point out, though. So for all of these studies, the risk reduction that is conferred to these patients, to these subjects, does extend to about 30 years. So it is sustained within the population for up to 30 years once once the person has stopped taking OCPs. Now, the same cannot be said for breast cancer because in breast cancer, OCP use has been associated with a slight increased risk of breast cancer. But when OCP use is removed, that slight increased risk sort of subsides. So, what I found just looking at the literature is that OCP use is there's some convincing data out there to show that it does reduce ovarian cancer risk, and that's largely why we decided to pursue the study.
So now you and your group have done a lot of work on opportunistic salpingectomy. Can you tell our audience what is opportunistic salpingectomy? What's the rationale for performing this procedure?
Yeah, so now we're getting into my primary domain. So this is where I've done a lot of work. So opportunistic salpingectomy is the procedure where the fallopian tubes of women are removed at the time of their surgeries. It could be a hysterectomy or in lieu of tubal ligation, while still maintaining the ovaries in place to prevent ovarian cancers. So, a lot of this work actually started back in 2010. Um, so, uh, so largely, when when a high risk mutation carrier, such as the BRCA mutation carriers, um, go in for surgery, primarily these individuals will have both their ovaries and their fallopian tubes removed. And the main reason for this is because it's sort of unknown what the impact of leaving the ovaries or leaving the fallopian tubes is on uh, on ovarian cancer risk in the BRCA mutation carriers. So it's best to just remove both to try to decrease the risk of ovarian cancer for those patients. And a large body of evidence suggests that the origin of ovarian cancers, specifically high-grade serous carcinomas, which are the most lethal gynecological malignancy, is the fallopian tube. So the notion was that if we had removed the fallopian tubes, then we would effectively prevent ovarian cancers. And if we remove the ovaries, because it's unknown whether the ovaries themselves give rise to ovarian cancer, then we would effectively reduce ovarian cancer. Now, if we apply the same logic to the general risk population, so that is the population that does not have an underlying BRCA mutation, so there's some negative effects, negative implications of removing the ovaries within this population. Primarily, you would put that woman into early menopause, and this is associated with a variety of cardiovascular implications, osteoporosis, and just a decrease in the quality of life of that individual. So, about I'd say it's been about two, 15 years now, 20 years. So like around 2010, researchers here at the University of British Columbia, what and this was work primarily done by Dr. Diane Miller. What they had proposed is let's remove the fallopian tubes while leaving the ovaries intact and see what the impact on ovarian cancer is. Now, if we fast forward to now, what we've shown in data is that it's effective at reducing ovarian cancers in the general risk population. And in 2022, Dr. David Huntsman, Dr. Gillian Hanley, Dr. Blake Jilks, and the team at the Ovarian Cancer Observatory that we had set up, which is a team of pathologists, gynecological oncologists from around the world, what we've aimed to do is look at the effectiveness of opportunistic salpingectomy in the general risk population um, for ovarian cancer prevention. And what we've identified is that it is effective at reducing ovarian cancer. Now, there's still a lot more work to be done in this field, and we're still chugging away at, doing analysis. But I'm here to say that, yeah, like a lot of other work that has been done has been like it's shown that there is a benefit for ovarian cancer risk reduction when the fallopian tubes are removed for the general population.
So you speak about three precursor lesions for high-grade serous ovarian carcinoma. What are they, and what data do we have about them to support this theory?
Yeah, so the three lesions that currently exist primarily include the p53 signature, the serous tubal intraepithelial lesion, which pathologists call the STIL, the serous tubal intraepithelial carcinoma, which pathologists call STIC lesions. And these lesions are considered precursors to high-grade serous carcinomas, which, like I mentioned, are the most lethal gynecological malignancies. And there's actually been quite a bit of evidence so far trying to link these precursor lesions to high-grade serous carcinomas. So one recent study looked at genomic analyses. So they used a procedure called laser capture microdissection to capture small pieces of tissue. They ran genomic analyses and found clonal similarities between stick lesions and high-grade serous carcinomas, primarily at the level of p53 mutations. So what they identified is that the same p53 mutation was found in the high-grade serous carcinoma and the stick lesion. So that's sort of some evidence there to suggest that there is a relationship between these stick lesions and the cancer. But it's still sort of difficult to uh, completely link these lesions with high-grade serous carcinomas. So a lot of a lot of work has been done and is ongoing in this field to try to link those lesions with the cancer. Um, there are significant differences between what a p53 signature is and what a still and stick is. So primarily when we define what a p53 signature is, it's actually what pathologists define as 12 or more consecutive uh, secretory cells that have p53 expression. And so these can range, like we mentioned in the paper, they can range in size from being about 12 cells, or they can go up to about 100 plus cells. And following that, which um, we're suggesting is the next step in the progression towards high-grade serous carcinomas, is what we call a still. So a still is like sort of like a less well-defined stick. That's how pathologists classify it. And a stick lesion is something that is more progressive and appears just before uh, the high-grade serous carcinoma. And so a stick is largely characterized by aberrant p53 expression and also a high proliferation index. So high levels of a marker called Chi67, which is a marker of proliferation. And the rate of appearance of these lesions within fallopian tubes and fimbria seem to be about the same, but the fimbria is considered the high risk portion of the fallopian tube, primarily because it's adjacent to where like a lot of that follicular fluid tends to uh, be when ovulation occurs. But generally, within the population, the prevalence of sticks and stills ranges from about 2 to 6%, and the prevalence of p53 signatures tends to be higher. It can range anywhere from 26 to 40%, depending on what cohort you look at. But yeah, a lot of these lesions, they are like a lot of people are doing work in this field to try to link those lesions with greater certainty. So.
Yeah. I was wondering if you can clarify. So the P53 signatures, how are they related to stick lesions?
Yeah, so these p53 signatures, so I'd like to just step back a moment and say that these p53 signatures, not all of them actually end up transforming into high-grade serous carcinomas. So it's still quite unknown whether the p53 signature and still or stick are completely related. So there's a lot of work still being actively done to show the relationship between these two. But the way that it's been characterized in the past and also is still currently being characterized is um, by looking at these p53 variations that occur between the stick and between the p53 signature. And there's actually been quite a lot of studies done in BRCA mutation carriers. So that's again that high risk population where they show that uh, specifically in that population, the incidence of p53 signatures was between 23 and 40%. And so, yeah, so they sort of linked p53 signature and sticks in that sense. But yeah, like overall, the link between specifically a p53 signature and a stick, uh, there actually isn't much evidence out there to suggest there is a link. We know that it is a precursor to sticks and stills, but in terms of like linking them together, that's one of the fields that we're actually looking into, uh, just trying to investigate the biology between those two lesions.
So now let's get into this study. What was
Yeah.
your hypothesis for this study?
Yeah, so when we went into the study, we actually went in thinking that there would be a difference in the frequency of p53 lesions between OCP users and OCP non-users. And this is largely based on other papers that have shown, this is primarily BRCA mutation carriers that have shown differences in the frequency of p53 signatures between OCP users and non-users. Now, performed the when we performed our analysis, we noticed that there was actually no difference in frequency of p53 signatures between OCP users and non-users. And then that led us to revise our hypothesis, thinking that there is probably some change going on. And so that led us to our a new hypothesis, which was that there would be a difference in the size of p53 signatures.
So with that, then, what was the methodology that you used for this study?
So primarily for this study, we used a retrospective cohort. So we basically looked back in time, looked for both OCP users and non-users within the general population. So a lot of this work was done by linking databases. So in order to extract those patients from our databases, we had to leverage the use of the BC discharge database. So this is a database we have here in BC where we can look at when individuals had surgery and when they were discharged. And then we took those IDs and linked it to something we call the BC PharmaNet. And so this is basically a database that allows us to look at drug use. And that's where we got whether people were using OCPs or were not using OCPs. So once we linked those two databases, we came out with a population of individuals who used OCP and did not use OCP. Now, when we went into the study, we went into the study looking for people who were at standard risk, so those who did not have underlying BRCA mutations. And the way that we filtered, so if the database presented those patients, those individuals with a BRCA mutation, they would be automatically filtered out from our analysis. As well, if they had a risk-reducing salpingo-oophorectomy, they would also be filtered out from our database because likely those individuals are at higher risk, which is why they're getting that surgery done. So once we had our cohort presented, so this was about 250 individuals, well, we looked for corresponding slides and had them stained for HNE, Chi67, and p53. And then we had 3 independent observers count the number of cells for each p53 signature that was identified by our gynecological pathologists. And so once we did that, we did a set of analyses using various statistical methods to come up with our results.
So, and also for our international listeners, BC database, BC stands for British Columbia.
Oh, yes. Yeah.
So now let's talk about the results. 250 patients. What were the highlights of the study? What did you find?
Yeah, so this was actually quite interesting, like I mentioned before. And the main finding that we identified was that between OCP users and non-users, there was a difference in the size of a p53 signature. And so this was a bit different than what we had seen based on other papers. But like I said, those papers were done in BRCA mutation carriers. So identifying that there was a difference in physical size was something novel to us. Another difference that we had identified was that p53 signatures found within the fallopian tube and the fimbria, there is actually no difference in the number of p53 signatures between those two anatomic locations. And this has been identified by many other papers in the past as well. So yeah, those were primarily our main results of this study.
Great. So Ramlogan, as a tradition in this podcast, we often will ask several questions from the fellows in the International Journal of Gynecological Cancer. And this first question comes from Kira Fischer at the University Hospital of Heidelberg in Germany. And she asks, assuming that a human fallopian tube is about 7 to 12 centimeters long, how did the authors choose the location of the sections stained for p53 lesions? How did they ensure a representative sample to not underestimate the occurrence of p53 signatures?
Yeah, so that's a great question. So what we try to do is we try to use the whole sections from each block, and we had a pathologist scan the entire section um, for each individual who used and who did not use OCPs. Each of these lesions were, like I mentioned, they were verified by pathologists. So in terms of underestimating the number occurrence of p53 signatures, most likely it we did underestimate p53 signatures because it's sort of difficult to get an accurate representation for the entire fallopian tube and fimbriae, largely because the CFIM protocol was not applied in this case. That being said, we applied the same measures in both our OCP users and non-users. So any bias that would have occurred likely did not because the same procedure was applied in both cohorts. So yeah, we try to actually represent the entire fallopian tube and fimbriae, but of course, it's not always possible to get all segments of the tissue. So, but what we had is what we analyzed, and those are the results that we came up with. But yeah, that is a very good question, though.
Okay. This next question is from Manel Montesinos Albert from Valencia, Spain. And he's asking about the mode of what is used, oral contraceptives versus IUDs. Could it be scientifically valuable to differentiate between oral contraceptive pills and IUDs, intrauterine devices, considering that IUDs offer more reliable treatment adherence compared to oral contraceptives?
Yeah. So for this question, this is an interesting question because in recent years, the use of IUDs has increased quite significantly. And there is actually limited data on the use of IUDs and the risk of ovarian cancers. And I I guess it's going to be like many years from now is when we're going to know what the effect of IUD use is on ovarian cancer risk. But based on what we know so far, it seems like that there is a beneficial effect to using IUDs, specifically the IUDs with progestins. However, the effect is less than a combined oral contraceptive pill. So the combined oral contraceptive pill, which is largely what was used by patients in our study, consists of both estradiol and progestins. And so some of these studies, like I mentioned, earlier studies found that there was a significant decrease in the risk of ovarian cancer. However, those studies, what they had looked at is, um, uh, so when they had looked at the use of IUDs, there was also the use of OCPs before that. And so like the effect would have been larger. But more recent studies have looked at just the use of IUDs, and it is less than the use of both combined OCP and combined OCP. So there are likely differences in the outcomes of EOC. And so this still has to be investigated. And I think we should differentiate the two. But what's really important to note when we're doing these studies moving forward is whether combined OCP was used, the type of IUD that will be used in these patients, um, and also how we can track uh, ovarian cancer risk over time. And it's actually, so I was actually speaking to my mentors about this, and it's actually quite concerning because when you look at SEER data, the use of IUD is on the rise for people in the younger population, and the use of OCPs in that younger population is on a decline. So we're sort of reaching a point where the use of an IUD will increase beyond the use of what an OCP uh, is. And so if we're going to have this sort of a large use of IUDs with a lower impact to ovarian cancer risk, then the question will be in the future, will ovarian cancer's risk increase over time for like population? So that's still not known. Like the number of ovarian cancers that might occur in the future may increase, It's still unknown whether, you know, that will happen, but so far, I guess we need a lot of large-scale epi type studies in order to see that effect. But yes, I do completely agree. We do need to differentiate the two.
Excellent. So now this next two questions actually come from Canada, from the University of Toronto, Stephanie Gill. The first one is somewhat on a related topic as you were just speaking. She writes, the manuscript states there was no data on the type of OCP used, but were you able to determine if it was estrogen plus progesterone or progesterone only? And if so, did you include both in your analyses?
Yeah, so unfortunately, given it's always given the limitations of databases, we did not have that data on the type of OCP used. Although that is a great question to ask, because like I mentioned, combined oral contraceptives versus progestin-only oral contraceptives could make a difference. However, given the time period that our study was conducted, so this was early in the 2000s, it would have largely been combined oral contraceptives, so both estradiol and uh, um, progestin. So this is largely, at least in Canada, what was being given to patients at the time. And I think it makes about 96% of the pills that were given at the time were these combined oral contraceptives. So, although yes, like we didn't look at it, I would think that it would be like something else that we could look at in the future to see if we can get that data and see if we see the same effect. But I suspect we most likely will see that effect, given that there's some evidence linking progesterone as the active component in reducing ovarian cancer risk. So, um, yeah, so it would be an interesting question to follow up with.
Okay. Her second question is, do you know if the rate of p53 expression at your institution increased after the CFIM protocol evaluation of fallopian tube was implemented? And if so, by how much? I wonder if this would give us a better understanding of how many p53 mutations may have been missed or undiagnosed in this study. Your thoughts?
Yeah. So that's a great question as well. In terms of the rate of p53 expression at our institution, so about 2010, 2011, we did do a study. It was just like a small internal study to look at the number of stick lesions that we could identify in individuals who had a CFIM protocol. So it was a small cohort, about 400 individuals. Pathologists reviewed sections of the fimbria and identified that there were zero stick lesions. And so pathologists had a choice to make. Do we continue to perform the CFIM protocol for individuals at general risk, so just people who do not have a BRCA mutation, or do we stop that given what we've seen? And so what was done was that the CFIM protocol to general population risk individuals was stopped, largely because the benefit of uh, seeing these lesions versus um, the amount of time that was spent reviewing the slides, uh, and the benefit was very small. And so typically, I think in terms of like the number of p53 mutations, quite possibly some may have been missed, but the jury is still out on what clinical impact p53 signatures have on just like general like risk protection for ovarian cancers, primarily because, like I mentioned before, it's still not known whether p53 signatures, uh, whether all of them do become high-grade serous carcinoma. So even if we're reviewing them, it's still unknown whether those p53 signatures will transform into something more carcinogenic. And so, if we look at the number of salpingectomies that we currently do in BC, British Columbia, so we've done like about 37,000 salpingectomies. So for pathologists to review uh, 37,000 fimbria using the CFIN protocol would I think would take a lot of time off away from like other things. So yeah, so that's the approach that we took. But that is a great question as well, and something we should follow up with.
Okay. This next question from Julia Gellison in University of Wisconsin-Madison. She asks, are the relatively high rates of p53 signatures, approximately 30%, in your population similar to findings from other cohorts? And if so, how do you think providers can use knowledge of a p53 signature in practice, given the large differences in incidence between 53 signatures and ovarian cancer?
Yeah, so on the p53 signature, the rate of incidence is about 23 to 40%, and we have found similar rates within our cohorts. But yeah, it's actually difficult to identify how useful a p53 signature would be in clinic. And like I mentioned, it's so first of all, it's like I mentioned, it's not known whether p53 signature will progress into a still or stick lesion. And as well, like, even the methods of trying to capture a p53 signature uh, while the fallopian tubes are uh, in the human body is still, it's like physically impossible to do that. Usually a lot of the work that we do on p53 signatures could is done either in mouse models or which there are very few of, or it's done after the fact. So after the fallopian tubes are removed and the fimbria is removed, then we do p53 signature analysis. So in terms of how clinically relevant it would be to look at p53 signatures, it's sort of difficult just given the size of these lesions and also given where they are within the fallopian tubes and fimbria. But knowing and understanding the biology of p53 signatures and how they progress to stick lesions is necessary, primarily because if the effect that we're seeing with the use of OCPs happens to be applied to many patients, then it could be beneficial from a preventative standpoint. And understanding the biology of the transition is just better for us to understand how we can use different treatment modalities to possibly reduce those signatures.
So now this next question comes from Thomas Bartel at the Medical University of Vienna. And he's asking, is there a molecular rationale why oral contraceptives exposure may reduce the size of p53 signature, but not their number?
Yeah. Thought about this question when we were writing the manuscript. We looked at the literature, and honestly, there isn't much about the molecular aspects of how the OCPs could impact the physical size of p53 signatures. And it's primarily because this is a novel finding. No one has really shown this in previous work. But I would hazard to guess that based largely on other papers, so other contexts, and this is primarily done in cancers like colorectal cancers, that size does play a role in whether a lesion will progress to a carcinoma. So in one paper, for example, they looked at colorectal cancers. They looked at the lesions that occur. I think they're called serrated polyps. So they looked at those lesions and they found that smaller lesions did not progress to a carcinoma at the same rate as what a larger lesion would progress to. And so if I were to think about or hypothesize how we could reduce the size of a p53 signature, quite possibly what could be happening is that the active component of OCPs, which is largely that progestins, could be having an effect on the size. How? It's still unknown, but there is one study that has been done in transgenic mice looking at p53 mutations, where they've shown that uh, progestins or progesterone does target TP53 mutations for necroptosis, so for cell death. And so quite possibly there is something going on in there in terms of how OCPs are reducing the cell size. But it's still, yeah, a lot of work still has to be done in that area.
Very well. So now this next question comes from Clara Santia in Houston, Texas. And she's asking, previous studies have identified a higher number of p53 signatures in BRCA mutation carriers who never used OCPs. Do you have any data on the BRCA status of patients with p53 signatures in both groups, those who used OCPs and those who did not?
Yeah, so this is a great question as well. And our papers are primarily limited to the historical data that we have on hand. And so at that time, not individuals were like there weren't like BRCA testing was not routinely done. But for those individuals who had BRCA testing done, like I mentioned, they were filtered out. For anyone who had risk reducing salpingo-oophorectomy. So those are those high risk individuals. They were also filtered out. And so the individuals within our study were at standard risk given those factors. Now, it would be beneficial to follow up in a subsequent study to see what proportion of those individuals are BRCA mutations, if carriers, if they are. But given the criteria that we used, we try to filter out as many of those individuals out as possible.
Now we're going to go back to Manuel Montesinos from Valencia, Spain, and he's asking what factors could account for the difference in the protective effect of OCPs in reducing the size of p53 lesions in the general population compared to the effects observed in BRCA mutation carriers, and how might genetic predisposition shape these outcomes?
Yeah, so yeah, I hazard to guess that a lot of this boils down to the biology of the fallopian tube epithelium. So within BRCA mutation carriers and within just the general risk population, there are small differences at the level of the fallopian tube epithelium that exists between the two populations. And so one difference is quite possibly just the genetic background of those high risk mutation carriers could have led to quite possibly uh, um, uh, no, quite possibly like just a difference that would result in them having a difference in the frequency of a p53 signature compared to us not seeing that in the general risk population. Another thing that could be different between these two populations, so the BRCA and the general risk population, is that the BRCA mutation carriers, they have their fallopian tubes removed at an earlier time point. So quite possibly what's happening is that these p53 signatures don't have as much time to develop compared to individuals from the general risk population. So within our population, within our study, there were the average age of these individuals was about 50, which is significantly higher than the BRCA mutation carriers who are at they had their fallopian tubes removed when they're 30 to 40 years of age. And so that could have had an impact on possibly the use of OCP and p53 signatures. Also, something interesting is that when you look at how OCPs impact these cells, within a p53 signature, basically progesterone receptor tends to be lost as cells progress. Uh, and so quite possibly what's happening is that within uh, the general risk population, quite possibly what's happening is that progesterone receptor is being lost over time, and as a result, OCP's effectiveness is decreasing over time. And so that could also be a difference that's occurring between these two populations. But yeah, a lot more work has to be done in this area to look at the fallopian tube biology. So far, in terms of the use of OCP and not using OCP, there's been limited work done on just fallopian tube biology in general. And so actually our institution, like that's one of the questions that we're going to ask in later studies. Just what impact occurs within the fallopian tube biology when using OCPs.
Yeah, so exciting to see so many areas of potential future research in this area. So, Ram Logan, I want to ask you one last question. Certainly want to be respectful of your time. This last question comes from Julia Gellison, also again from the University of Wisconsin-Madison. And she asked, how would you build upon this study to further understand the relationship between OCP use, p53 signatures, and ovarian cancer?
Yeah, so that's a great question, and personally, I would love to study the fallopian tube biology. I think that's a great area to look at in order to understand how OCPs are is impacting the fallopian tube, because that will give us insight into the progression of the disease at an early time point, and then we could implement preventative and therapeutic strategies for these individuals. If the p53 signature is identified early, or if the stick lesion is identified early. And so it's interesting to note that when we look at fallopian tubes within a tissue block, we sort of take away from like the natural history of that p53 lesion. So we don't actually see it in real time progressing. And as a result, it can sort of, alter our understanding of what's actually going on. And so I really think that model systems, so functional studies involving mice, for example, is necessary. Like we need to recapitulate these lesions in vivo in order to understand their trajectories. But I also appreciate the fact that we need large-scale epi studies as well to basically show how the use of an IUD or the use of OCPs with just progestins will impact future ovarian cancer risk protection. So, yeah, there's a lot of areas, and I hazard to guess we're gonna sort of like, reach out to all of those areas and do some studies. But yeah, there's a lot of work to be done, and it's an exciting future.
Well, Ramlogan Sowamber from the University of British Columbia, thank you so much for taking the time to answer our questions. Thank you for accepting our invitation to do the podcast for the International Journal of Gynecological Cancer. Congratulations to you and your group. Really exciting work. And it seems after this discussion, a lot of exciting work to be done in the future. So thank you so much once again. And we look forward to you and your team at the Journal Club.
Thanks for having me.